Hi, I'm Dr. Howard Zucker, the doc in Docology. There are 7,000 rare diseases that are out there, and 25 million Americans are actually affected. 95% of the illnesses are illnesses that we basically have no treatment for, and many are not even being studied by scientists. So, as a result, drugs that are not approved by the FDA for that specific diagnosis are being used anyway. So, that's really called off label use. And that sounds like a problem. Well, it is. And today's guest, David Fajgenbaum, is a doctor with a rare disease who did something about that exact issue. He figured out how to repurpose a drug to treat his own condition, Castleman disease, which he'll explain to you what that's about. And then he wrote a story about this in his memoir, Chasing My Cure. Then he went on to co-create a foundation called Every Cure, where the goal was to use existing drugs to help other people with their rare diseases. So basically, it's hope, science, perseverance, and basically thinking in a different way. That is what our guest is all about today. So, Dr. David Fajgenbaum, welcome to the podcast. Thank you for joining us. I I thought maybe what we
Howard, thank you so much for having me
oh
on.
great, thank you. I thought maybe what the best thing we could do to start with is maybe if you could tell us the big picture about your own story, the moment you realized that something was wrong, and then the journey forward from that point, and then we'll get into questions. I have a lot of questions, so maybe we could start with that, just the big picture of your disease diagnosis and the process from that going forward.
Sure. I was a healthy third year med student at Penn, which sounds like you also trained at Penn. And out of nowhere, I became critically ill with this disease, which was eventually diagnosed as idiopathic multicentric Castleman disease, and spent months and months in the ICU. I even had my last rites read to me before the diagnosis was made. And with that diagnosis came lots of chemotherapy, really with the last ditch effort hope of trying to save my life. But I kept diagnosed or kept relapsing over and over and over again, and eventually was told that I was out of options, and there were no more drugs for my disease, which was heartbreaking, devastating. But I also thought to myself, well, what about all those chemotherapies that were tried? None of them were made for my disease, and they seemed to they worked short term, but they were able to help. So I thought to myself, maybe there was another drug that was made for another disease that could also be repurposed for me. And then I discovered this drug, sirolimus, and maybe a bit more about Castleman's. It's a hyperinflammatory cytokine storm disorder where your immune system attacks and shuts down your vital organs for an unknown cause. But thankfully, we can now treat it with drugs that our groups help to identify.
So it's sort of an immune problem, is you're saying, just so that, for those who are not scientists or doctors like us, basically your body is not able to fight off some of these infections in some ways. Is
So
that
it's
a point?
it's actually it's the opposite. It's that the
Or
immune system is
overreactive,
is so
overreactive. Yeah. Yeah. Sorry, go ahead. Yeah.
powerful, exactly, that it actually just destroys your vital organs.
Well, so that, and how long, what was the period of time from when you were first diagnosed until you started to recognize that this particular off-label drug would work? And then also, how did you move forward to sort of say, okay, let's take this on, let's do something much more creative?
So I was sick for about 3.5 years. Spent a lot of that time in the hospital. 5 deadly flares of my disease. Before I went on the search to try to find sirolimus, I spent several weeks working in the lab, performing experiments on my blood samples, flow cytometry, serum proteomics. Did some experiments on my lymph node tissue, and after doing that work, I pulled all the data together, and there was this really strong mTOR signature in my blood, and I thought that maybe using an mTOR inhibitor, which had been around for decades, might be able to turn the disease off. And so I started testing it on myself back in January of 2014. And so now it's been 11 years that I've been in remission on this medicine.
Amazing, amazing, amazing. It's sort of like history. Some of these scientists and doctors back, years ago sort of say, okay, well, I'm going to tackle this on my own. I'm going to try to figure out the solution on my own. And that's what you, in many ways, you did. So there are thousands of these rare diseases out there. And I mentioned at the beginning that 1 in 10 Americans basically has one. And I'm sure I know the answer is going to be money to this, but why are these so under-researched? And whether it's Castleman disease or other things, why do you think they're so under-researched?
It's a great question. I mean, I think that the main reason, of course, is because they're so rare. It's hard to garner the resources you need to do the work. So I think that's one part of it. I think that there's also a piece that us we tend to go after areas maybe there's something to build upon, there's some basic foundational research, and now we can take it to the next level. And rare diseases, oftentimes no one's done the ground the foundational work, so it's really hard for researchers to come in and to jump off from it.
And so you started this foundation basically to sort of say, okay, I'm going to take this on not only for what you did for yourself, but for many other people out there. Can you share a story about somebody else that you have helped over the course of the last handful of years that also is sitting in a situation like you're in, that you were?
Sure. Yeah, absolutely. So maybe I'll share one from the early days, and that was a rare cancer called angiosarcoma, which was uniformly fatal. And a patient named Michael was diagnosed with it. He spent about 3 months receiving chemotherapies that weren't working, and it was out of options. There were no more drugs that could be useful for his disease. And I did something really simple, Howard. I searched PubMed for angiosarcoma treatment, and I came across a paper that had been published 3 years earlier indicating that among 5 tumors that were stained, 4 out of the 5 had increased PD-L1 expression. And this is 2016, so there were a couple of PD-1 inhibitors that were approved. They had never been used before in angiosarcoma. But based on that biomarker data from other cancers or from other patients, I was, well, maybe we could stain this patient, Michael's tumor, for PD-L1 expression and see if maybe he could respond to a PD-1 inhibitor. And so we did that, and it came back very positive, and we started Michael on the PD-1 inhibitor, the first patient that we're aware of
I think you froze though.
to receive it. And it worked. It's now been over 9 years that he's been doing great on this PD-1 inhibitor. And the reason I think this is one of my favorite examples is that because it worked so well for Michael, and because the cancer was uniformly fatal, this spread very rapidly to where lots of other patients with angiosarcoma got tested for PD-L1 expression and eventually got started on PD-1 inhibitors. It turns out it works in about 1/3 of patients with angiosarcoma, and it's now actually in guidelines for how you treat angiosarcoma. So it's one of my favorite ones because the data was already out there. It required no brilliance on our part. We didn't have to run any experiments. We didn't have to do anything to find it. Someone had already done the hard work, but it was just sitting out there, and no one was taking any action to get this medicine into people. And that's really part of the inspiration behind Every Cure and creating this nonprofit. Not only do we know that there are drugs out there that can save more lives, we actually also know that there's data out there that can point to those drugs treating diseases, and machine learning is particularly well suited to find those data points and to make those connections. So that's really why I started Every Cure, to make sure that no patient suffers like Michael did or like I did when there's a treatment that's out there, and that we utilize AI to find all of these opportunities and move them forward.
I was going to mention AI in a second because I thought that that's really like the future of where we're going in medicine. But I do want to say, just for those who are listening, that you can a lot of the terms that we're hearing are and the names of these diseases we don't hear. We don't. It's not like diabetes, hypertension, because these are those rare diseases that are out there that no one hears about on a regular basis. So when Dr. Fajgenbaum mentions them, that's exactly what one of these challenges are. And there are thousands of these diseases like that. But I wondered if you could mention about AI and what you think where we can move forward on that.
Sure, I'm extremely enthusiastic about the power of AI to help us to find more uses for medicines. So right now there are about 4,000 FDA and EMA approved medicines, so drugs that are approved either in Europe or the United States. And depending on what naming system you use, there's somewhere around 18,000 diseases. If you were to try to count every single disease out there, the ones you've heard often and the ones that you haven't heard. And so if you were to try all 4,000 of those drugs for all 18,000 of those diseases, it would be 75 million shots on goal, basically 75 million times you would try each drug for every disease. And there's no way that any laboratory or team could ever conceptualize the likelihood of all 75 million of those matches. So, sirolimus for Castleman's or whatever the match may be. And there'd be no way for humans to ever be able to compare what are the best ones out of 75 million possibilities. But actually, artificial intelligence is really, really good. It's scanning across the world's knowledge to come up with an assessment for how likely every drug is to treat every disease, and actually give us a normalized score, meaning that every drug against every disease gets a score from 0 to 1. If it's close to 1, a 0.99, that means that our algorithm, our machine learning algorithm, thinks that that drug is likely to work for that disease. And if it's close to 0, it thinks it's unlikely. And so we're able to utilize the world's knowledge, everything the world knows about every drug, every disease, every gene, every protein that's publicly available. And we train these algorithms on known treatments because we know that there are thousands of drugs that work for thousands of diseases. So we can train the algorithm on the patterns of connections for known treatments. And then we ask the algorithm, okay, now score the likelihood of every other drug to treat every other disease out of the 75 million possibilities. And what's great is you see things at the top that you expect, drugs that work, that are being used off label, are effective. And you also see drugs that you never even would imagine to be towards the top. Recently, Botox for depression scored very highly. And we looked into it further, and there's some interesting mechanistic data as to why Botox might be helpful for depression. But it's this really exciting moment where rather than going one drug, one disease at a time, like we did for my disease, for Castleman's, like we're now able to say, let's use AI to look across every drug and every disease to find the very best opportunities. So we, as a nonprofit, Every Cure, can then either do laboratory work or clinical trials to move that thing forward that otherwise wouldn't be moved forward because 80% of drugs are already generic, which means it's not profitable to find more uses for those medicines. And as you know, the majority of diseases out there are actually very rare. So again, there's very little incentive to do more work with them.
Amazing, really amazing. This is one of the biggest positives I think AI will provide to healthcare delivery, and so that's very encouraging. Going back for a second about the fact that they're off-label, did you notice whether they're off-label in other countries? Because that's our FDA. But what happens, Germany has a equivalent of FDA, EMEA, which is the European equivalent of the FDA. What'd you
Yep.
find when you were looking both for your own condition, Castleman disease, but in other conditions as well?
Yeah, it's a really important point because you're right. There isn't just one regulatory agency that governs the world. Every country has its own regulatory authority, or it relies on a regulatory authority separately. So you're absolutely right. So in my case with sirolimus, it had never been used before anywhere in the world for my disease, for idiopathic multicentric Castleman disease, and so there was no one to turn to understand what they thought about this drug for this disease. But you're right. There are other drugs out there. We actually just chatting today with my medical team about hydroxyurea. It's very effective for sickle cell disease, and it's used widespread around the United States. And it's approved in most countries around the world and in many countries in the continent of Africa. But there are actually countries in the continent of Africa where it's not approved for use and where it's not even accessible. And so that's a case where like it's approved in the vast majority of countries, it's used, but there's some countries where there are a lot of people suffering from sickle cell disease and this medicine is not even approved for them. So it's technically off label. And we've got to figure out ways to make sure things don't fall through the cracks. I mean, that's why we created Every Cure, is that like when a drug's out there that can help a person suffering from that disease, we got to make the connection. And hydroxyurea for sickle cell disease is like the ultimate example where like we know it works. How can there possibly be people suffering on our planet that could benefit from it? But again, that's the spirit for why we created Every Cure, is that we believe every patient who could benefit from an existing medicine should be able to benefit from that medicine.
Yeah, I'm as a pediatrician, I learned a lot about sickle cell, and I do know that the team down at Hopkins was working also on some of this issues with hydroxyurea. So I'm kudos to all those who are working on this. This brings up, you mentioned sort of like a policy question of what to do, but there's
Yeah.
another part of this that I'm very curious about, which is the insurance issue. Because so now you've taken a drug that's off label and you've sort of said, and that probably is expensive or potentially expensive, and you want to use it. Did you have any challenges when you were trying to get the insurance companies to cover medicines either for you or for any of those who you've helped?
Howard, that's such a great question because you're right. Once a drug is approved for one thing, any doctor can prescribe that drug for any disease where they believe the benefit outweighs the risk. And Howard, as a pediatrician, you prescribe things off label all the time, right?
That's right.
So that is completely legal and it happens often. 1/4 of all prescriptions in the US every day are off label. So doctors are prescribing things off label all the time. So doctors can do it, and they do. They do a lot of off label prescribing. Your point is exactly right. The big question is, will it be paid for by the insurance company? Now, if the drug is expensive and it's not approved for that use, there's a high likelihood that the drug company is going to deny the request. And so now the patient might have to pay significantly out of pocket, or they're just not going to be able to access it. The good news is that 80% of all FDA approved drugs are already generic. So so anytime we uncover a new use for a medicine, there's an 80% chance that that drug is already generic. There's already multiple manufacturers and it's already relatively inexpensive, which means that if it's a bad disease and it's an inexpensive drug, then the insurance companies are very, very likely to cover it. Now, if it's a not so bad disease and it's a very expensive drug, insurance companies are very unlikely to cover it. And there's, of course, a spectrum to this. But if you're dealing with severe diseases and relatively inexpensive drugs, insurance companies generally will cover this. And like the drug that I'm on, sirolimus, there were no questions asked. No one with Castleman's had ever been given sirolimus. Immediately approved it, and that's in part because it's an inexpensive drug, and probably also because they did the math and they see how expensive I am when I'm sick, and I'm very inexpensive when I'm healthy.
Well, it's all about prevention, right? You're preventing a problem, whether
That's
it's a
right.
chronic disease or not. You're preventing the problem from ending up back in the hospital and having the problems
Exactly.
that happen being in an ICU or just even in on a regular ward. Part of the whole healthcare system has really become topsy-turvy in many ways. And as one who's been through the system as well, doctors, and we all know this, they don't have enough time, right? 15-minute visit, it's almost impossible sometimes to get a doctor in a reasonable period of time to see you. So how do we get them to address rare diseases? Because I will tell you, once I went through the system myself with something which was, unusual and self-limited, but I went from doctor to doctor. So how do we get doctors to sort of say, okay, I need to sit down, listen to your symptoms, and try to fit this into a diagnosis. And it's not so easy to do. So I was wondering, did you experience that when you were going through all this? And what would you recommend to you others, to your patients, and to others about this?
It's such an important question because how could it be that every doctor knows something about all 18,000 diseases? I mean, it's unrealistic. So you're exactly right. The challenge is how do you, as the patient with a rare disease, or you as a physician with a patient with a rare disease, make sure you can get them to the right diagnosis and get them the right treatment? I'm a huge proponent of physicians reaching out to other physicians for these, we call them curbside consults, as you know. It's like, hey, I've got this friend from med school who I think studies these kinds of diseases. Let me get their advice. Or maybe I read a review article about these kinds of diseases. Maybe they'll have some perspective on the right diagnosis. I just think it's really important that clinicians phone a friend and that they do get some more collective knowledge, because there's no way that we could know about all 18,000 diseases. And so that's one. I think that you got to be really willing to reach out to your colleagues and see who's writing review articles on these sort of symptoms. That's one. Two is for the patients, and that's to feel empowered to go seek other opinions. I think that the vast majority of doctors are very open to their patients going to seek out other opinions, but the vast majority of patients are afraid that their doctors are going to be upset with them for going to see another doctor. So there's this disconnect. Doctors are open to it, but patients are fearful of doing it. And so I think we got to break down that disconnect. So patients should feel comfortable going to seek out a second opinion or just other thoughts on the condition. At the end of the day, we, the patients, are the ones that are battling these diseases. We're the ones who have loved ones that will have to deal with the suffering and the sadness if we die from our conditions. And so we, the patients, should feel empowered to be able to seek out additional feedback and guidance. And then I think my third comment might seem a little surprising, and that's that as artificial intelligence continues to improve, I really do think that AI is going to be at diagnosis. There are already really interesting anecdotal reports and also even some published studies of ChatGPT and other large language models being able to come to diagnoses where humans were not able to. Or you could even compare ChatGPT to a team of doctors, how they come to diagnosis from, let's say, the New England Journal of Medicine CPCs, and they're performing just as well, or in many cases, outperforming physicians. And that's not to say better than all physicians. That's crazy. It's just that having a resource like that to be able to help maybe a physician who's not familiar with those conditions, I think is going to be really helpful and important. And it's going to be a bit of growing pain, and I think it's going to be a little uncomfortable for those of us in medicine. But I think we got to use it because we've got a problem, which is we got people with horrible rare diseases that aren't getting diagnosed rapidly enough. The average time of diagnosis for a rare disease is about 7 years. For a disease like Castleman disease, you can't miss the diagnosis for more than a few months or else you're going to die. So like I went 11 weeks without a diagnosis, and that was the maximum I could have gone. If it was 12 weeks, I would have died from my disease. And so we don't have the time to wait. We can't stick with the status quo. of these long times of diagnosis, and we happen to have a solution that can maybe help to speed these things up.
It is what you mentioned before is exactly what I've experienced with one of my friends who's afraid, was not afraid, went to another doctor, but they're always worried, like, well,
They
maybe the
are
first
worried.
doctor's going to be upset that I said, no,
Yes.
just this is your health. You go and you seek out whomever you need to speak with. And most doctors, I have always said this, most doctors are
Yes.
comfortable with it. They think it's great. Find talk to someone.
Of
I dealt with this
course.
all the time. You'd say, okay, go talk to another
Yeah.
subspecialist. And then you often come back and say, they said the same thing. It's like, okay,
Yeah.
right, right. That's exactly what happens. But the system is very impersonal. And so I was wondering, you know, we're in medicine, so we sort of know how to navigate the system, but how do you make people who are not in medicine feel empowered? This is one of the challenges to say, go seek out other people, go ask about possible off-label drugs, and how do you empower others to do that? It's not an easy task.
It's not easy. You're so right, Howard. It's very challenging because, to your point, there's this dynamic where these patients feel so grateful that their doctor has helped them to get them to where they are. They're so appreciative, and now you're trying to encourage them either to seek out a second opinion, or maybe to ask them, well, what about this off-label drug that I came across online? Sometimes doctors will say, don't consult Dr. Google. They'll sort of preemptively say, don't do that. And I know why doctors say that, because it can be frustrating. But I think that patients need to hear that, appreciate it, understand that their doctor, knows these diseases better than anyone else, and at the same time, still feel comfortable asking the questions and saying, not, hey, doc, I want to take this medicine, but hey, doc, I came across this paper or this study or this patient who I heard receive this medicine, and this is why it looks like it might have helped them. Help me understand, like, how you would think about a medicine like this. So not telling them prescribe this, but just asking them, how would you think about the risks and benefits of this? Because at the end of the day, it's a shared decision making process, and anytime a medicine is used off label or experimentally for a condition, it's got to be a joint process between the physician and the patient and the loved ones. We can't forget about family members of patients. They're just as critical to this equation as anyone else. But I think it's about encouraging them to ask the questions as opposed to demand or tell them, but really ask the questions. And then also, I really can't emphasize enough how helpful disease organizations are. So for the I wouldn't say the majority, but for a lot of rare diseases, there's a disease organization where there's a mother or a father or a patient with a rare disease who has started a group where they know who the experts are. They know sort of what are the cutting edge treatments and what's coming down the pipeline. They hear anecdotally about patients who've benefited from medicines. And so I think one place to go to feel more confident that you're asking the right questions is to go to your disease organization and ask them, hey, what are the things that are sort of on the leading edge? What are the kind of questions I should ask? And then if you feel like you've now been given those questions or you're informed by your disease group, you might feel more confident to ask the questions to your doctor.
I will tell you, I know of my own patients that two, right off the top of my head, two that started foundations just about that. One was kids with epilepsy, and another one was about something called black Van Diamond anemia, which is
Yeah.
basically a blood disorder. But their kids were sick, and they decide they're going to take this on. And what you did as well, you did the
Yep.
same thing with Castleman disease, and that's just taking a proactive stance and saying, I'm gonna fix this, not just for myself or my relatives, but also for those moving forward, which is important because in a lot of ways, you almost feel like an orphan in the system, right? You feel very isolated when you have something and someone, the system can't put you right into a specific box right away. And with everything pushing so fast, it's sort of hard to do. What do you think about what's happening with the health system right now and with I know it's a policy question, but is research being cut back? And we have a cabinet secretary who is looking at these things from a different vantage point, and some of the things we've spoken about on this podcast we're very concerned about. Will the research funding be cut back for things like these rare diseases? And what do you think will happen with that?
It's a great question. I think we're all still sort of uncertain about which programs or diseases might have more cuts than others. I think that the jury is still out on that. I think that the one thing I will say is that the work and the data that's been generated over these decades and centuries by biomedical researchers that work serves as the foundational ingredient for the AI algorithms and platforms we're using. And so when we discover or identify that adalimumab might be a treatment for Castleman's, or we think that certain drugs might be useful for Poem syndrome, that's based on the work that's gone before us. The algorithm is only as good at making connections as the data that it's making connections based on. And so we need to continue to fund basic biomedical research to better understand how diseases work, how drugs work, how genes and proteins work in the body. Those insights will then serve as the ingredients we need for artificial intelligence to find these patterns and these connections. And so I can speak firsthand that I'm alive thanks to work that have been done even before I started doing laboratory work, because we understood that phospho-6 is a great marker for mTOR activation. So therefore I could and I can determine that mTOR is up in my case. And so all that to say, we need to keep pushing for biomedical research. You sort of never know how that biomedical research, that fundamental research, will end up helping a patient, because sometimes you might learn a lot about a gene in diseases, but then you'll learn about a gene that is very relevant across many diseases. So I don't know which ones or what disease areas may have cuts, but I do know that it's really important that we push forward science as much as we can.
Well, that's the one thing about science, which is great. Is like you start down one path and you end up helping people with other conditions. Are there on the ones that you've helped people with rare diseases, are there some that you can list and say these are the three or four that I've really made a major dent in for other people that the public may be aware of? But in general, which ones have you tackled that have been great successes so far?
Yeah, I'm really proud, as you can imagine, of what we've done in Castleman disease. Obviously, I'm alive because of that work, and a lot of other patients are as well. Very proud about the work and
I, I missed that one.
about pembrolizumab, and they've had sorry, for angiosarcoma and the effect that pembrolizumab has had in angiosarcoma. And the third one is DATA2 syndrome. DATA2 is a rare inflammatory condition where children were dying from having strokes, multiple strokes over the course of their lives. And a researcher about 20 years ago did the work to determine that a TNF inhibitor could be helpful in DATA2. And it was many years before an amazing physician named Chip Chambers, who has children with DATA2, came around and started saying, well, let's get this drug TNF inhibition to patients all over the world. And I was honored to partner with Chip to get guidelines developed for DATA2 syndrome. So that way patients around the world get this TNF inhibitor. So what you maybe will hear from this discussion is that we can use artificial intelligence to discover new uses for medicines, like we did with adalimumab for Castleman's. We can use AI to discover medicines where more research is needed, like we're doing with lidocaine across a number of cancers. So research in the lab and also in clinical trials. And we can also use AI and partnerships to uncover cases where the drug has already been proven to work, like etanercept for DATA2, but it's just not being utilized. So help us to find those opportunities, and then we can do the work to develop treatment guidelines and get the word out about them. But there's a lot of opportunity for medicines out there to be used in new ways, and I'm so proud of just those few: Castleman's, angiosarcoma, and DATA2.
Excellent. One thing I will say is that high school biology, for all those who are listening, everyone says, well, I learned a lot of these things in high school biology, and the amount of medicine and the complexity of the human body is just really fascinating. And for those who have studied it and gone through, whether it's medical school or PhDs of physiology, you start to realize how all these different things connect. And you mentioned like TNF, and I can go through all, we can go through all the science to it, but it takes so long. But I think the big thing to mention here is that there are so many different pathways that the body deals with when it comes to whether it's infection or, as in your situation, overreacting to inflammation of our body, but all the other problems that we have. And if we keep studying and using research and experts who are out there, we can really make big differences. And you mentioned about research that we do need to keep pushing that forward. I was curious if you could share a little bit about how going through the health system changed your approach to medicine, because I want to hear your view, but I know it changed my approach when I dealt with the system for just a quirky, self-limited problem. So you've been dealing with this system for a while. So how did it change your approach?
Yeah, great question. I think that the first thing that it did was it just gave me such gratitude for all the various players and stakeholders across the system. As a medical student, I was a third year med student when I got sick. I had a medical student or a physician centric view of how the healthcare system worked. And then when I became a patient, I learned that doctors engage with their patients, a few minutes a day in the hospital, but those patients engage with so many other professionals for the other 23 plus hours a day. And so just a tremendous amount of gratitude for, and then when I say gratitude, of course I'm not saying for everyone but doctors, also tremendous gratitude for all the doctors too, but really just gratitude for all the people that are part of the system. That's one definite takeaway. Another one is a tremendous sense of urgency, and that's that before I was a patient, I think that I was okay with timelines that we normally have in medicine. So, like, it costs $1 billion and takes 15 years to create a new drug, and that's just the way it is. And there's a drug in development for this disease. There's not one for that disease. And the reason that there isn't a drug in development for that disease is because the work hasn't been done yet to prove it. But being in the system and being a patient created this tremendous sense of urgency where I've realized that, yes, that's the way things are going in our system. And that can keep happening, the slow, long, expensive path. But my eyes were open to this bypass pathway. And that's that, well, what if we use one of the drugs that's already out there in a new way for this disease? We may not be able to cure the disease, but maybe we can significantly treat it with a drug that doesn't take $1 billion in 10 years, and we can help the patient with tomorrow instead of a decade from now. And that sense of urgency has just asked me to ask a lot of questions and push a lot of boundaries as much as I'm able to, as much as I think I should. But I think that it was that urgency of being a patient, realizing that just being told, sorry, there's no other trials going on in your disease. I mean, that's what I was told. I was told, David, we've tried everything. There's nothing more that we can do. There are no more trials. There aren't even any leads. Like, if we wanted to do a trial, there isn't a lead for a candidate or a target or a pathway. There's nothing to go after. We've tried everything. But as I shared, I discovered there's a drug that we hadn't tried yet that was able to save my life. It's now been 11 years I've been in remission. And so every day I'm like reminded, with every breath I take, I'm reminded that there are more opportunities out there, but they're not just going to appear because for the vast majority of these there is no financial incentive to find them. They're old drugs. 80% of drugs are generic and cheap. They're very rare diseases, meaning small populations that could take these medicines. So the vast majority of great opportunities out there, there's no economic incentive for anyone to find them. So if there's no incentive to find them, that means there's no incentive for people to look for them. And so this sort of urgency that I've got is very much to say, let's find as many of these as we can to help as many patients as we possibly can.
One of our former guests was Nancy Brinker, and one of the things she said, every no is a maybe. So I think that I keep thinking about that, which is an important point.
Yeah.
One quick question on just your perspective on things. If you were able to go back and have a conversation with yourself, imagine just like going back to when you first learned of your diagnosis. So what would you say to yourself? Like, what would be, you get it, you have a diagnosis, and now you're trying to figure out a course of therapy. Like, what would that conversation be like?
Wow. Yeah, I'm actually just getting emotional thinking about it because I wouldn't have believed. I wouldn't have believed that I would still be here. I wouldn't have believed that I got married to. I was dating a girl named Caitlin back then, 15 years ago. We got married. We got two amazing kids. All the things that I was dreaming of doing, and that I was frankly that I was just devastated I would never experience, was I wanted to discover drugs for diseases. I wanted to take care of patients with horrible conditions. My mom had died from cancer a few years before I got sick. And so I felt this tremendous sense of unfinished business. I'm going to die from this disease before I ever got to take care of patients and my mom, before I ever got to follow through on the promise I made, because I promised her that I would dedicate my life to trying to find treatments for patients like her. And I just had this horrible sense of, just sadness that I wasn't going to be able to do that because I was sure, my doctors were sure, everyone was sure that I wasn't going to survive. And I think just, I just wouldn't have believed myself if I said, listen, 15 years from now, you're going to be okay. And I was no way. No way that's possible. But again, that's what just drives me so much, is that there's a lot of other people being told every day that there's nothing else that we can do. And maybe there is something else we can do. And if there is, then we got to find it.
Well, I think with that point, those are, very, you know, heartfelt words. And I think that I want to turn to the our subscribers in a second, and I thank you for those comments. But are there three takeaways? I mean, you mentioned some, but are there three specific takeaways you think that we want everyone to remember regarding rare diseases, and also what you have gone through?
Sure. So I think the first one is to always seek out advice, guidance, second opinions. Don't ever stop. Ask your doctor, go online, ask Dr. Google, ask ChatGPT, reach out to the disease organization. As much as we want our doctor to have all the answers for us, we have to realize that for rare diseases, we've got to be our own best advocates. We've got to drive forward things ourselves. And again, we don't want to do it. We wish our doctors would deliver everything to us. And for some diseases, we're able to. But if you have a rare disease, you've got to take on the job of being the project manager for your rare disease. And you've got to take on being proactive in finding solutions. Again, we don't want to do it, but we got to do it. So that's number one. Number two is that sometimes there's a solution out there that's hiding in plain sight that could be helpful for you or for your patient if you're treating a patient with a rare disease. That doesn't mean that there's a drug out there that can help them. I don't believe that. I'm not naive to this idea, that we can treat every disease with every drug we've got. But I do believe very strongly that if there's a drug that we already have as humanity, and there's a disease that could benefit from it, and there's data that already link that drug and that disease, that we have got to make sure that we can evaluate whether that drug works in that disease. If there is data, we got to find it. We've got to find the connection. We've got to evaluate it in the laboratory and in clinical trials to make sure that no one suffers if there's a treatment that already exists. And then maybe the third thing I'd say is more of a general comment, and that is that all of us need to reflect on what we're hoping for and we're wishing for. All of us in our daily lives, we hope for things and we wish that this will happen or that'll happen. We got to listen to what we're hoping for, listen to what we're wishing for. And then we need to start asking ourselves, what can I do today, tomorrow, and the next day to get the world closer to the thing that I'm hoping for? And there's a lot of things that we actually don't have power over in our worlds. Like there's a lot of geopolitical things happening that hope and wish all we want, but we've got no control over it. But when it comes to our own health, there actually are things that we do have control over. It may not feel like it, but it might be that you have to go to Little Rock, Arkansas, like I did, to find the world's expert for Castleman disease. And he would have the solutions needed to keep me alive long enough for me to find a drug that could save my life. And so you've got to be proactive, and you've got to ask yourself, what am I hoping for? And if I'm hoping for something, what can I actually do to get closer to that thing I'm hoping for?
Excellent. Those are absolutely wonderful, wonderful points, and we will make sure everyone in the audience hears that when we do our takeaways. At this point, we usually go to our subscribers, which we're going to do now. But I want to mention that the podcasts are for informational purposes, and we've been speaking a lot about medicine and a lot about the health system. But if you do have a medical problem, do speak with your doctor, because
Yes.
they do know your medical history, and they can tie all the different things that you've been through in your medical history and course of any particular illness together. So stay with your doctor, or if
Yes.
it's not the right doctor, find a doctor that can help you. So we're going to turn to Kat, but did did you want to mention anything about that?
Oh no, just that I fully agree with you, 100%.
Excellent. Thanks, Kat. Let's go to our audience. You usually have the first question, and I'm sure there are a lot
Yeah,
today.
I have the
Yes.
first question, then I have two folks that I'm going to bring up for questions for Dr. Fajgenbaum. I really appreciate you coming on today. Your story has been super inspirational, and it,
Yeah. Yeah.
I really appreciate it.
Thank you.
I'm curious what you think, if there's a disease area or disease areas that are ripe for sort of repurposed drugs and some sort of breakthrough in the near future.
Yeah, this is a great question. So, we look across all 4,000 drugs, all 18,000 diseases. So everything is within our algorithm. Every disease is considered. But to your point, there are certain classes of diseases that are maybe more likely to have drugs that can be repurposed. We found that autoimmunity and cancers are two areas where there's a lot of opportunity, and it's for a couple of reasons. One is that Howard mentioned earlier this idea of pathways that are important across diseases, and it turns out that in autoimmunity there are a small number, a limited number, between 5 and 10 pathways that are critical across dozens of different autoimmune diseases. And so you can hit one pathway with one drug, and it turns out that that pathway is important across multiple diseases. And the other reason is that there are actually a lot of drugs that already target the immune system. And the reason for that is that autoimmune disease drugs have been developed for many years because it's actually a very lucrative financial area. So that means that there's just a lot of drugs that target the immune system. Same thing for transplant and also for cancers of the immune system. There's just a lot of drugs out there that modulate it. So many opportunities to help or to target parts of the immune system, and many drugs that already target various opportunities or various places in the immune system. So I think autoimmunity is one very clear area, and then cancer is another one. And that's in part because so much research has been done into cancer. So we really understand the molecular mechanisms and underpinnings of many cancers. And we also, again, have a lot of drugs that already exist in the cancer space. So I'd say those are probably the two areas that I'm most excited about, or at least most optimistic that there's a lot of opportunities waiting for us.
Great. Thank you so much. I really appreciate that. I'm going to bring up Anna, who has a question.
Hi.
Hi.
Hi, Dr.
Hi,
Fajgenbaum.
Anna.
Nice to meet you. Hi, Dr. Zucker. Yes, I want to just echo what Kat said. Dr. Fajgenbaum, you are a remarkable person, and I can't even imagine what you are like as a doctor. You're probably just absolutely incredible. So thank you for being on this episode. I have actually two questions, and I guess you could pick which one you want to answer. One is, what's the biggest myth about drug development that you'd like to bust? And the second is, what's the wildest idea you've pursued that actually worked?
Oh,
You don't
great
have
question.
to answer both, but you can pick your favorite.
Great questions, Anna. It's so good to meet
Great
you.
question.
So for the first one, I think that the biggest myth is that we often think that when there are no treatments that are available, that's because everything's been tried and there's nothing left to try. But the reality is, as you know, in drug development, a drug gets developed for 1, 2, 3, maybe 5 different diseases, and it's not evaluated across the thousands of other diseases out there. So just because a drug hasn't been tested in a disease doesn't mean that it's not going to work in that disease. And then the converse is that it's important to keep in mind that there are many diseases out there where no one has ever done any research whatsoever. So again, just because there isn't a drug that's been established to be used for that disease doesn't mean that there isn't actually a drug that could be used for that disease. I think that's number one. And then wildest idea that I've pursued that actually worked. I'm actually going to change the question a little bit and say the wildest idea I've heard about being pursued that actually worked, and it's something that listeners will be somewhat familiar with, and that's the drug Viagra. Most people are aware that it was repurposed from heart disease to its very well-known use, but most people don't realize that it was also repurposed for a rare pediatric lung disease called pulmonary arterial hypertension. So children that were dying in their teenage years because they weren't getting enough blood flow to their lungs can now live a full life on low-dose Viagra. And I think that's such a great example where no one would think that erectile dysfunction and a pediatric lung disease are similar at all. Like you would say, like, kids dying because they're not getting enough blood to their lungs and enough oxygen to their tissue. How could that be similar to erectile dysfunction? But the reality is that both conditions involve vasoconstriction and limited blood flow to an area of interest. And in this case, thankfully, a researcher thought, well, maybe we could increase blood flow to the lungs. It turns out that it's really effective and it's really life-saving.
That's
I,
awesome.
you know, I'm going to add to that because I'm a pediatric cardiologist, and not only is it used for like pulmonary hypertension and kids and older kids, but even newborn babies who have a high blood pressure into their lungs when they have certain types of complex heart diseases that they're born with, you can use that drug or a variant of that drug, whether it's not a pill necessarily, but something put into an IV to help improve their blood flow to their lungs and in many ways save their lives. So
Incredible.
what started in one area has spun off into many other areas as well.
I love that.
All right, I'm going to bring up, thank you, Anna, for your question. I'm going to bring up James, who has a question for you.
Hi, Dr. Fajgenbaum. Thank you so much for coming on this podcast. My question is, can you tell us some stories of other patients with rare diseases who have approached you for help?
Sure. So maybe I'll share the story of Alan. Alan has Castleman disease, which is the same disease that I have, and he wasn't responding to any medicines. And it wasn't him, but actually it was his doctor who approached me about saying, my patient's tried everything. Could you try something else? And we looked at the top scoring results from our algorithm from the Matrix, our Every Cure platform, and it identified adalimumab. I mentioned it quickly earlier today. The top scoring drug for Castleman's hadn't been used, but it was interesting. And at the same time, my laboratory had discovered a strong TNF signature, which is what adalimumab targets in the blood of Castleman's patients. And so we thought we should try it in a last-ditch effort to save him. And amazingly, it worked. And this, for me, was so exciting because it was the first time that I'd seen an example where AI could actually come up with a new treatment that wasn't being used. So AI is really good at finding patterns and can sometimes point us to, this drug looks promising, you should use it more, and then we'll study it further. But this is a case where it was really a de novo identification, which was just so awesome. I mean, it was a little bit over 2 years ago. And for me, that was this moment where I was like, wow, these AI platforms are going to be so powerful. Of course, I can take something that's predicted for Castleman's and get it into use very quickly because that's the disease that I study. But all I could think about is all the other conditions that could benefit from that sort of power.
Gotcha. Thank you.
Mm-hmm.
Thank you. Dr. Z, teeing it off back to you.
Okay, sure. Well, there are so many different issues. I am so pleased with what you are doing because you are saving lives, both with rare diseases, but also sending the message out there that anything is possible. And I think
Yes.
that that's really important, not only for the public, but also for young doctors who are in training. And I know you're down in Penn, and I know the system well, as you mentioned, and I trained there, and they're energized, and when you go and speak with them, I'm sure that they recognize that anything can be achieved, and there are some superstars down there. We even had Doug Wallace, who's a mitochondrial
Amazing.
expert from
Yeah.
CHOP, right? He was on the podcast a couple of weeks ago, and he took on issues of mitochondrial disease and tackled that. And I will mention, I just throwing out another name. Because of what we were speaking about, is someone who has passed away, but Judah Folkman also was at CHOP at one
Yeah.
point in training. He was a doctor who had an idea about how cancers grow, and
Yeah.
that they grow because blood vessels feed the solid tumor
Yeah.
cancers, and no one believed him initially. And this was way back in the 1950s, and it took many years
Wow.
until people started to realize that what his theory was correct. And as a result of that, there are many drugs that are out there today that are drugs that stop these cancer blood vessels from growing into those cancers. So we never know where things can go. And I think that it's just having the inspiration like you do to sort of say, I'm going to take something on and I'm going to figure out how to help people. And you never know down the road what can happen. And there are many stories from the institution where you're at right now at CHOP where people have taken diseases, particularly congenital heart disease, which is what I was working on down there. And years ago, the kids didn't make it, and today they survive. So I thank you. Your story is incredibly inspiring, as a researcher, as a physician, but also someone who lived through the system. You saw the gaps in the system, and so you did something about it, which is amazing. And you saw a vision. You were fueled, I guess, by the urgency, and you made something a reality. So, and I think I was thinking about this a little bit while you were speaking that, if you want something done right, just do it yourself. And so you did. I mean, that's not my quote. I think that was Napoleon who said that. But that right, I think it was a historical line.
Yeah.
And you did it. That's what you did. So your extraordinary work has helped in many rare diseases. So I thank you, and I thank you on behalf of so many people and for coming on the show today. So I appreciate it. I look forward to seeing you. Maybe when I get down to Philadelphia, I'll grab some lunch with
Love
you and
that.
have more of a conversation. That is it for our show today. Next time on Docology, we're going to be joined by someone who has been at the heart of health policy in America for decades, and that is the former Secretary of Health and Human Services, Tommy Thompson. He played a key role in shaping some of the most important health initiatives in our country for literally for decades. And for me, it's personal because Secretary Thompson was the person who introduced me to public policy when I joined his team as a fellow many years ago. So I look forward to it. I think it's going to be a great conversation. It's going to be filled with insight, with stories, and probably his reflections of healthcare policy from a true leader. So remember, if you are a Docology subscriber, you can join the conversation. You just have to sign up for the email reminders about the upcoming episodes. You could do that at docology.life or on Substack. And tune in next time, because the topic we cover may just save your life. Docology is a production of Hang Media. Our producer is Catherine Warren. Ronnie Selig is editorial advisor. Our creative director is Anna Richard. Janine Wilson of Wilson Media Group handles paid marketing. Our publicists are Leslie Ann Wade and Jerry Caracoli. Theme music was composed by Nick Kitts. Subscribe and join our community at docology.life. Until next time, move, wash your hands, and stay healthy.